promoting health population, value for money, and as well as providing better experience for our care provider as well. So the outcome of the strategy was, one of the outcomes was to provide a service to the patients to be able to see their health records online and real time, which led us to have a patient portal in Fraser Health for our patient population. What is Patient Portal? Basically, Patient Portal is providing access, is a tool that provides access to the patient, to their own health record. They can access to their data is available for them 24/7 from anywhere. They can use desktop, laptop, tablet, mobile. They can view their own information, health record information, which sits in health authority, so they have view access to their data, as well as they can provide or upload more information, which is, like we call it, personal health records. If they want to track things, they can record in the tool. Some of the portals also have available functionality that the patients can share information via portal with their care provider or with their families. So Fraser Health decided to go with MyChart. We partnered with MyChart, with Sunnybrook Health Science in Ontario, to leverage MyChart as our patient portal in Fraser Health. MyChart provides clinical information, view access to the patients. It has record sharing capabilities. Patients are able to share their records with their family physician, with their families, friends, and basically the control is under patient's control if they would like to give access to some, to none, different level of access to all the information that they have in the portal or to subset of information that they have in the portal. Patients also are able to upload any documents that they have. They can see their appointments in the portal. They can track their mood, blood pressure, any health-related information that they would like to enter into their portal. So with that, we decided to go more like in a small scale to be able to have a deeper implementation to promote success. Our project started with a pilot with renal patients with 5 clinics in Fraser Health. And the scope of the project was subset of clinical documentation from Meditech. Meditech is our EMR system. And also patients are able to provide personal health information, weight, height, blood glucose, etc., mood tracker, and patient education materials also available for these patients. They have, for example, for the pilot, we have renal patient education materials available in the portal. So we went live in April 2019 with 5 clinics. After the pilot, we expanded to all renal clinics in Fraser Health. Now we are in operation and we are expanding to other clinical areas in Fraser Health. So with that, I hand it over to Brianne to explain to us the challenges that we have. Thank you.
So as with any project, there are many challenges you face. So one of our first challenges we faced was the pediatric population. So to start, we excluded the pediatric population and went with an age of 19 to register for MyChart. This is because with the legislation, the definition of a mature minor is very vague, and it's up to healthcare provider to decide if they are mature minor to have their information. So for that, we didn't know when to give the MyChart over to the pediatric patient, so we decided to exclude, but we are working through this process. Another challenge was the request of information process with Fraser Health. We were changing this. It's a manual process. And there are certain things that you're supposed to exclude to give to the patient when they request their information. Some of this is third party or cause for harm. And so when we were providing this electronically, we were bypassing that manual process. So we created some templates for clinicians to chart in electronically, and in which they could put that information in. With that, the other major challenge is we were changing documentation practices for clinicians. So we were asking them to chart in another template, although with our audits, they've only had to use it twice so far. As well as we were asking them to change some of their charting with respect to objective versus subjective charting and chart with a patient view in mind. This, though, drove quality because we were actually just reinforcing best practices. And then the final challenge, main challenge we faced was patient health literacy, which we worked on with the patient education module in MyChart. So for this project to be a success, we had to deploy a very large change management strategy. This was, we knew, was the most important part of the project. It would dictate the success and whether the patients would uptake and adopt the MyChart, as well as clinician promotion of MyChart. We used ADCAR method for change management, and we focused on not just what we were rolling out, but how we were rolling it out. And that's why we kind of focused on that small-scale, deep implementation, so that we can incorporate lessons learned as we went. So as with any pilot project, evaluation's key. So we were evaluating three main things for this pilot project. We were evaluating our portal, so its options, its usability. We were also evaluating the information we had available in MyChart, so what reports and our patient education. And then we were evaluating our change management strategy. So we used a logic model with Fraser Health Evaluation Services and a mixed method design to evaluate both qualitative and quantitative data. And we evaluated both patients and clinician experience with MyChart. We also performed some audits on charting, audits on the templates we used, and audits on some of the other charting to ensure that some of that FIPA information was not included in the regular charting. So what we learned. So for clinicians, we learned it's important to engage early, create champions and advocates for change. That would really drive the success of the project and promotion with patients, which we'll discuss with the patient learnings. We were really disrupting practice, but out of that came innovations, which we worked with some of the dietitians in the renal program with. And then that top-down and bottom-up approach, creating advocates in the front line, as well as having executive support and support at all levels. For patients, we learned that the usage and adoption of MyChart is really benefits-driven. So you need those high-value reports in there for them to adopt and use MyChart. So some of those reports were lab and diagnostic imaging, which we weren't yet including, but are working towards. The other main change is self-management. Lesson we learned is self-management. So that's really impacted by their technology savviness, as well as where they are in their course of the disease. And again, like I said, the collaborative clinicians. If they promote it and to use it when they come into their visits, and that sharing of their report, that would really impact the patient adoption. And then these are just quickly our next steps because I'm of time. This year, we're just focusing on expanding our reports, expanding to cardiology and community respiratory services, adding more patient education, and we're really trying to develop a packaged approach and a momentum for a Fraser Health wide rollout and adding our other clinical information systems. Thank you. And there's our information.
So if there are questions, please put your hand up, and I see a couple of hands right away. So one at the front and one at the back. Wait for the microphone to get to you. Go ahead, Vikram.
Is the microphone on? Okay. I have a couple of questions, actually. Fraser Health, I understand, is our largest health authority in the region, but why would we, Fraser Health, not be working with the other health authorities? Because my records all in 4 different health authorities, so I'm not going to have different records everywhere. So I want to find out that question first.
Okay, so totally recognizing that with all the other health authorities, it's important for patients to have that one-stop kind of shop and have everything. So one of the benefits with MyChart is you can upload anything from any other health authorities. But the other thing is that right now this is just kind of ground level, and the idea would be to when other health authorities come on board with patient portals, or if they do, to integrate with them, and we can kind of join in some of that work so that the information can cross those.
So ideally, you're hoping that at some point there's one patient portal for everything, and the information will be at all different health authorities.
Yeah, or different patient portals, but they all link together, and you can get your information from different ones. That would be the hope.
Okay, fair enough. Okay, the second question was about pediatrics. You mentioned as a challenge, but why did you not consider that the parents would want to know what's going through their kids and want to be able to access those records versus the kids themselves?
For sure, and so that is definitely a consideration. My former career was a NICU nurse, so I worked with babies, and I know that parents would want that information in there. So we do recognize that. We just want to work through the logistics of that first with privacy, because at some point when that child becomes a mature minor, they take over that. So when is that? So we want to, what is the process on how that happens, and what's the dialogue that happens with that? As well as there are some other fine points that we have to work through. For example, if a child, if there were any issues like an infant of a substance-using mother, and they didn't know about that, and then do they then get that record and have that information shown to them? So there's kind of a lot to work through. So we do definitely want to get there, but just have to work through all of that and kind of have our I's dotted, T's crossed before we do that.
Okay, thank you.
Yeah, hi, it's Frank Irvin. I tried to sign up just at the start of your presentation. I said, oh, that's great, let's do it. And I noticed, and I understand that you're at the pilot stage, and I didn't succeed, obviously. But I did notice that to sign up, you have to actually go to a clinic in the hospital and sign up there. You can't remotely sign up. Could you comment on why that is?
So yes, that's true. So the registration currently for MyChart is in-person registration, and the reason for that is the registration clerk, they need to see the valid ID from the patients and make sure that the identification process that we have is followed properly. Although the goal is to have automated registration, we put this request and waiting for the approval to be able to, with the technology, to be able to validate the identity, and patients over time be able to use automated registration for MyChart.
Yeah, like I'm thinking of the Life Labs interface that doesn't seem to require in-person sign up. And did you look at that?
That's the goal.
That's the goal. That's it.
There's a question here.
Hi, I'm just wondering what the level of patient uptake has been, and if you've identified any barriers to that that might be helpful for other people to learn from.
Do you know how the patient numbers are? Okay, so currently, again, it was just the renal program, so it's over 80 patients that have signed on to MyChart. That should go up this year with cardiology and CRS coming on board. And the barriers to uptake have really been kind of in that patient learning one in that middle, some of the demographics. So, for example, when we rolled out to the chronic kidney disease group of the renal program, that we had great uptake. They're early on in the stage of their disease, and they can really self-manage. But when we initially went out to some of the in-clinic dialysis units, and they're in end-stage renal failure. So that's kind of some of the uptake challenges, as well as the other challenge is that benefit-driven. So getting those kind of high-value reports on board quick. So, and that's kind of what we're working through this year with diagnostic imaging.
Excellent. Go ahead.
Have you been in contact on a provincial level with this rollout, and are they making any motions as far as moving forward on a provincial level to do the patient portal?
So we are working towards a ministry strategy for the patient portal. We recognize that some health authorities, they have their own patient portal. For example, Interior Health, they have their own portal. So as Brianne mentioned before, is we are at the beginning of providing portals to the patients. So health authorities, they may go for individual portals, and then at the end, the goal is to provide one platform for the patients to log in and pull the information from different portals behind the scene. So for the patient would be one-stop shop that they can see their information.
So thank you so much for those great questions. And just as our B2 team leaves, let's give some applause. Next, I'd like to call upon the GPSC Patient Experience Tool, data source for quality improvement within primary care. Over to you.
Thank you. My name is Christina Thomas. I'm a project manager with the Community Practice and Quality Department at the Doctors of BC. And I'm here today to talk about the General Practice Services Committee, or the GPSE Patient Experience Tool. I did have a disclosure slide in there, but it just said I have nothing to disclose. Okay. The agenda's probably a bit overkill for a 10-minute presentation, but nonetheless, I'm going to briefly talk about what is the GPSE Patient Experience Tool. We'll take a quick look at the reporting dashboards and how participating clinics view their data. And then I'll briefly talk about the PSP Quality Improvement Facilitation Cycle and how this Patient Experience Tool work fits into that. I'll get into the tool implementation and the collaborative expansion strategy, and then I'll go into an example of the work we're doing with one of the local divisions of family practice, and then end off with a story about how the tool has been used in practice. So what is the GPSE Patient Experience Tool? Well, that is it right there. So it's a tablet-based survey platform. For those who are unfamiliar with the practice support program and kind of how it works, there's a provincial PSP office, and then we have 5 regional support teams, which are located throughout the province, and those consist of our coaches who are actually on the ground in the clinics supporting clinics and physicians with work, and this tool being one of those pieces of work. So the tablet is shipped directly to participating clinics, and then the regional support team coach is there to meet with the clinic to support them with anything they need in regards to the tool. So initially they're there to help them get it set up, take it out of the box, get them familiar with the tablet. There's a question bank associated with this tool, which the question bank consists of approximately 130 questions. The questions were all taken from validated sources, but they have been adapted for use within primary care within BC. So our question bank itself is not a validated tool, but the sources we took from are. The questions are all categorized into what we call dimensions of care. So there's 6 dimensions of care. And then the questions are also tagged by different content areas, and this makes it really easy for the clinics and the coaches to search the robust question bank to kind of filter out to see what they want to include in their survey. There are 6 GPSE selected core questions, or what we call them. So these 6 questions are mandatory to be included in all surveys. In addition to those 6 questions, we encourage participating clinics to select another 9 to 14 questions from the bank that are meaningful to them in their practices. Clinics have access to their collected data in real time through a web portal. So the tablet is merely meant for patients to provide their feedback, and all of the back-end work and information is done in the web portal, so that's where the surveys are created, the reports are pulled, and so So there have been efforts in the past to collect patient data in the primary care setting, and they've all been met with significant challenges. So this tool was built in direct response to those challenges, and it really allows participating clinics to focus on using the collected data to make quality improvements. So some of the benefits of using this particular tool are the fact that it comes on the tablet itself and it's easy for the patients to use. The tablet is easy and low maintenance for the clinics. Collected data is automatically collected and stored in a secure database housed in Canada. The reporting dashboard, which we'll take a look at in a second, makes it easy to analyze collected data, and it makes it easy for those clinics to identify the areas that they want to work on. The patient consent and privacy processes are already in place. There's no open-ended questions asked, so open-ended questions actually pose a liability risk to physicians if a patient was to mention they're at a risk of harming themselves or somebody else, so we take that out of this equation. And then also compensation is available for physicians and their team members, and Main Pro certification is available for physicians as well for work with this tool. So here's a view of two of the reports that clinics are able to pull from the reporting dashboard. The first one here is what we call the dashboard report. So it simply just shows the aggregate response for each question that the clinic has asked, and then the clinic is able to drill down by clicking on the See More option, and they can actually see the number of responses to each individual response option. The time-based comparison report is similar to the dashboard report, but is meant to do a comparison over time. So the clinic chooses two different time ranges. So theoretically, time range A would be just the initial collection of data, and then there would be a point where an action plan is made and an improvement to practice is implemented. And then time range B would be the time after that. So you could see, hopefully, an improvement in scores over time. And again, similar to the first one, there's the drill down option, so you can see the number of individual responses to each option. We worked really hard with lots of input from physicians to get kind of the colors right and to make the dashboard really easy to read and for them to get a quick glance and identify areas that they might want to drill down deeper into and make improvements on. So this is an illustration of the quality improvement practice facilitation cycle. So this is the cycle that is used for all of the practice support program work, but I'm going to walk through how it relates to the patient experience tool and how a regional support team coach would assist a clinic with this work. So the first stage there is the engage phase. So this is where the coach meets with the clinic and they literally take the tablet out of the box, get everybody familiar with it, answer any questions. This is also the stage where the coach will have those conversations with the clinic to make sure that they're actually at a point where they're ready to take on this work. It has happened in the past where you have one member of a clinic who's really keen on doing this, but everyone else feels like they're burnt out or over capacity, and it's not successful. So we learned the hard way that these conversations have to be had in this stage, and then it might just be that the coach says, we respect your willingness to do this, but maybe let's readdress this in 6 months. So that's engage. Moving on to the assess and learn. This is where the clinic and the coach talk about what areas they want to focus on, and the coach can help the clinics sift through that 130 question bank and identify the questions they want to initially include in their surveys. This is also where the clinic determines how they want to administer the survey. So the two most popular survey administration methods are handing the tablet to the patient in the waiting room before they get called into the exam room. And then the second is just having the tablet on the back of the exam room door that the MOA kind of alludes the patient that we have the survey. If you want to complete it, here it is. So those are the two most popular, but there are others like trying to hand it to the patient as they're exiting, which hasn't turned out to be all that successful. And then, in the assess and learn phase is where the surveying of patients starts. And we recommend that to get a good baseline of data, this surveying goes on for about 8 weeks. And then moving into the action plan phase. So this is where the coach and the clinic sit down to review the reporting dashboard, which we just saw, and they look for the areas that they want to improve on initially. They create their action plan and then begin to implement the changes. During this phase, the clinic has options. They can continue to survey patients while the action plan is being implemented, or they may choose to actually take a surveying break and then come back to it in the test and measure phase, where in the test and measure phase, they sit down to review the data again after the action has been implemented, surveying patients again. They sit down to look at hopefully an improvement in scores. And then if they're not seeing exactly what they would like, this is the time that they make slight adaptations to their action plan. And then moving on to the implement phase. This is where the coach and the clinic determine if the change to practice has resulted in the positive change that they expected. This is also where sort of the plan is developed to ensure that these changes are able to be sustained in practice. And then finally, we get into the sustain phase, which is just where the coach and the practice ensure there's capacity in practice to sustain this change. And then the clinic has the option of being done with the patient experience tool for now and sending it back to the PSP provincial office. Or if they choose to do so, they can recommit to a whole another quality improvement cycle, and then they can keep the tablet for as many times as they want to keep committing to that cycle. We anticipate that once through this cycle, we'll take a clinic anywhere between 3 to 9 months. Okay. So with the provincial implementation of this tool, there has been 2 streams so far. So the first stream is just being onboarding individual physicians and clinics. So they come to PSP either on their own or through our regional support team coaches, and we get them set up with a tablet and then support them through that facilitation cycle. Happening simultaneously is PSP is collaborating with divisions of family practice. So PSP, along with the RST coaches and the divisions, work together to kind of assess and determine what the pain point or area of focus for that division might be. And we help that division come up with their own set of division core questions that they'll then ask their members to include in their survey. So where PSP kind of plays a part in this is that we facilitate the transferring of data from the clinic to the division. So in the web portal, the division is set up with their own web portal, so they are able to log in and pull reports similar to what we previously saw. But of course, it would be the division aggregate for all of their members who opted in to share the data, rather than the clinic aggregate, which the clinics see. So the division collaborative work is still in the early stages, but we have had more in-depth or preliminary conversations with Fraser, Northwest, Mission, and Comox Valley. Fraser Northwest Division graciously allowed me to share the division core questions that they have selected, which are up here. Just in the essence of time, I'm not going to go through them all, but all of the questions fall either into access to care, therapeutic relationship, or nurse in practice. Okay, just going to end off with a quick story about how this tool has been used to make a practice improvement. So one practice in the Fraser Health Authority that implemented the tool heard from patients who provided their perspective on the practice's office environment, relationship with the doctor, interactions with health team, and confidence in their self-management skills. Results from the patients indicated that there was room for improvement in wait times and clinic access. The practice team, supported by the RST coach, used this feedback to initiate a number of quality improvement activities, including completing appointment forms in advance and helping patients plan for effective appointments by telling them what to expect. Through implementation of these strategies, the practice team was able to cut wait times by 2/3. So on average, a patient was waiting for 60 minutes to be seen by their doctor, and this was reduced to 20 minutes through data found through the patient experience tool. And that is all I have.
So we have time for maybe a couple of questions. We see one here, and maybe one or two more. Put your hands up, and we'll get mics to you right away. Thanks. Go ahead.
Quick question. Obviously, everything was in English, but I want to know, with the multicultural society we live in, how are you adapting with the language barrier?
So currently, it's the 6 core questions are available in 9 other languages. By early spring, our whole question bank will be available in those 9 languages. And the first question that the patient answers is which language you'd like to complete the survey in.
Thank you.
Hi, excellent presentation. I just wanted to ask, when you're giving tablets to a clinic, how many tablets do they get? And have you ever had any issues with the security of the tablet itself? Like not the data, but just the machine?
Yeah, good question. It's up to the clinic really how many tablets they would like. An optimal number is about 3 service providers to 1 tablet. More than that just becomes too overwhelming for the office staff to try to manage. This issue of the tablet security, that's more of an issue for the clinics, and a few are very worried about that. Our messaging is always we'd rather the tablets being used and potentially be damaged or go missing than just sit in a drawer not being used. In the 58 clinics who have participated so far, we've had 2 broken tablets and none that have gone missing. So it really hasn't been an issue. I should mention the tablets are locked down to this survey, so they have no other purpose. So there's really no reason to steal them unless you want to do patient experience surveys over and over.
Quick question. Thanks very much for your presentation. The improvement that occurred with wait times, I'm interested in how that was done and what the granularity of the data was. So if they were doing PDSA cycles, would be several iterations of one, and then followed with data that they can see what happens on a week-by-week basis. So that's sort of a question, or was it more of a before and after type of thing?
Yeah, I'm not an expert in this exact case. I could get those answers for you. I believe most of the improvements that we see are more of a before and after. There is the ability to be doing those constant PDSA cycles with this tool, and you can measure the data like that. Most of the changes, I will say, are just as simple before and after.
Like, it's good that there was an improvement. It may have been a just do it, or hey, they made it visible in terms of the gap in patient care. So that certainly would be valuable. Thanks. And it would be nice to know how they did it, though, to spread that improvement.
Yeah, right. Well, it was mentioned in there that it was including doing the forms before time, and then the office staff calling the patients in advance to let them know what to expect for the appointments.
One more question? I have one. Yes. Infection control. Do you give some guidance around how to clean and maintain the tablets, knowing that multiple people are using them?
We give very general guidelines, and we leave that up to the clinics to take on themselves. In the pilot phase, we did give protective sleeves with the tablets, and they weren't being used. They were more of a nuisance than anything else. So we actually leave the hygiene up to the clinics for best practices.
Other questions? Great. Some applause for Christine. And you are such a fabulous audience and presenters, staying right on time. Our third presentation is Improving with Patients Takes Time, and the results are worth it. Over to you.
Thanks, Chris. So good afternoon, everyone. My name is Marlene Apolczer, and I'm a Quality Improvement Lead with Northern Health, and I'm located in Prince George. My partner today is Sally Rosevear, and she's a patient partner who's also located in Prince George. And we really appreciate the opportunity to share with you the work that we've done and our partnership. Over to you. And we have nothing to disclose. Over to you.
Thanks very much. Compassion, commitment, and dedication. Marlene and I share these qualities. In today's presentation, we hope to demonstrate to you what is possible through authentic engagement and collaboration. My husband died in 2014 following a less than satisfactory care journey. As a nurse, I knew it could have and should have been much better. I'd say it was something I wouldn't wish on my worst enemy, and I know that vets treat pets with more compassion. Someone needed to be accountable. Most folks having experienced this sort of trauma would be too worn down to speak up. I chose to write a letter to the Patient Care Quality Office. I said I didn't believe that the standard of care that we had received was adequate, and that I hoped that after reviewing the information in my letter, there would be some changes in policy and attitude. None of this would help my husband Jack, but it could improve service and outcomes for future clients. Following this letter, I received an apology, and it was acknowledged that my letter highlighted some things that were not going as well as they had thought. Permission to use my letter was requested, and they wanted to use it for a case study, and I granted that. I left the meeting feeling that I had done my work, and this was in April of 2015. Although I had contact with and received further support from one senior manager, I was still unable to get all my other issues addressed by a number of other departments. Reluctantly, in August 2015, I completed the detailed paperwork required to request a review by the Patient Care Quality Review Board. I asked that my letter and supporting materials be used as a case study by all the involved departments, so that the exponential and compounding negative impact of a series of seemingly small errors or omissions could be realized. I said that once I was aware of all the necessary changes having been made, I would then feel truly heard. After full investigation, I received a 23-page document called a Complaint Case Report to the Review Board in April of 2016. And this was the first time that I really felt that my experience was validated, and it's still quite emotional for me to read. The review board met in May, and one of their recommendations was that Northern Health conduct a patient journey mapping session with me. I had no idea what a patient journey mapping session was then, but it seemed to involve a lot of careful, in-depth communication with me. And this is when and how I met Marlene.
Thanks, Sally. So that patient journey mapping session happened in September of 2016. And so leading up to that session, we had a couple of meetings with Sally to explain what the patient journey mapping session was going to be about. And it was a very typical patient journey mapping session. Brown paper on the wall, sticky notes, 2 facilitators, 1 to capture the information on the brown paper, 1 to conduct the conversation with Sally, with providers in the room. What I really appreciated about Sally is the questions that she asked through the process. Something that she asked of us as facilitators as we prepared for that patient journey mapping session is if she could tell a bit about her and her husband before we started the story. Knowing that it wasn't going to be a positive experience that she was going to be sharing, she didn't want that to be the only context for the providers in the room, to hear this negative story about she and her husband. So we were happy to grant that to Sally, and that's actually something I've changed in my practice of patient journey mapping session, that I always offer that to the individuals about them telling a story a bit about themselves, right? Like, these are the activities that I like to do, this is how many children I have, so it builds a different context of where you start the patient journey mapping session. So we did the mapping session, and then the next step was to validate the map. So bringing it back to Sally for Sally to look at the information and see that we had captured it correctly. When we did that, we had a few changes, and then we finished with what we thought was a final product. And again, what I appreciated about Sally is Sally asked questions about what now? We now have this one-dimensional piece of paper that tells a story, but how can it be used? And so Sally took that patient journey map and she added in some additional detail that she felt we didn't capture in the actual patient journey mapping session. So then what we had is we had a one-dimensional, very colorful, very pretty patient journey map, and then we had a script that went along with it that identified the additional information that Sally had offered at the different points of the journey. But again, Sally asked the question, well, what now? When she shares the information about the intent was to use her story as a case study, how are we going to use that in an active way? And so with the team that we worked with at Northern Health, both the team that leading up to the patient journey mapping session and then subsequently, where we ended up landing is we created a learning hub module. So it went from being a one-dimensional story to being this interactive story that was online. And so we can't show you the whole module today because it's about 20-25 minutes, but I'm actually going to take a minute to just show you a few slides, because what you'll see is Sally, we've captured Sally in the module, and we're really proud of that. So just one sec while we get this set up. Okay, ready? Okay, so early on Friday, Jack is deteriorating and has an ischemic attack. Sally calls home care in the afternoon, and a staff member comes by later that night.
When I call home care, I say I don't know where this is going, but it can't be anywhere good. Either this evening or the next, I mention to the nurse that maybe it's time for injectable meds. Without further questioning, the nurse tells me, then they would have to be given every 4 hours, or something similar. Jack is weaker, using his oxygen more, and has little interest in eating. At night he is restless, doesn't know if he wants up or to lie down again. Listen panicking. It is difficult for me to physically keep him from falling.
Sorry, that shouldn't be happening like that. There we go. So on Sunday afternoon, Sally and Jack watched ice skating. Jack used his walker to get back to bed.
I have to use Jack's walker to push him back to bed. This is the last time he is out of bed except to go to the bathroom, just 9 feet from bedside to toilet. Jack is frequently restless and panicking. It is difficult for me to physically keep him from falling.
So a home care nurse is scheduled to see Jack at 9 a.m. Tuesday morning. When no one arrives, Sally calls and is advised there is no appointment scheduled.
I am physically and emotionally exhausted. I have spent 4 days alone with Jack. No plan, no respite, no support, and now they say we are not scheduled for a visit. I call my doctor's office for help.
So I'm just conscious of time, and so I'm going to stop there. But that gives you a bit of a sense. You'll see that what we've done here, this icon above Sally's head, shows the emotion, because that's something we constantly ask in patient journey mapping is what is the emotion that you are feeling? So we were able to also capture that in the map. So what we wanted to share with you was a bit of, actually, do you want me to just hold this over here? Was a bit of what were our key learnings and the benefits of us working together through this. And so Sally, how about I let you go first?
Okay, I'd say that my key benefit from working with Marlene is confidence. On our first meeting, Marlene listened to me and was willing to make changes to her usual method of patient journey mapping. We trust one another, and I've had opportunities to meet and speak with a number of her colleagues, individually as well as participating in some group training sessions with her. This has boosted my self-esteem, increased my confidence in expressing myself in a large group, and allowed me to be here speaking with you today. My key learning is that communication is key, effective communication. There needs to be free and open communication between all stakeholders in healthcare. Everyone needs to be heard. Those in positions of power need to be true team players, taking a personal interest in how their decisions impact job satisfaction throughout the organization. Poor job satisfaction leads to burnout and does not promote good quality care.
For me, I'd say that I had two key learnings. So the first key learning for us in the system, we have to remember that when we're doing this work, this is our work, and it's the patient partners' lives that we're working with. And so I consider myself somebody who's pretty caring and understanding, and it took me a long time of working with Sally to have an aha one day that I could just park the work that we were doing on this and I could go home. And this was Sally's life. And so that was a real key learning for me. And I think the other key learning is that we in the system don't always need to know where we're going. Because I can tell you, we had no idea we were heading in the direction of taking this story to create a Learning Hub module. And so I think we need to be open to going on the journey with the patient partners to see where it takes us. Because I give a lot of the credit to Sally of where we ended up, and we in the system were open to going on that journey with her. I would say my key benefit to working with Sally has just been the opportunity to get to know Sally, because I think Sally's a pretty amazing woman, and how that's built my context for the importance of working with patient partners and how much value we can get from working with them and how the system benefits from that. And that's it.
Questions from the audience? Please put your hands up and the microphone will come to you. Oh, there's one. Great.
Thank you for sharing. I'm really curious, how did you come, I guess, so I've put in complaints before. I'm curious, how did it evolve from putting the review board complaint to getting to a place where you're actually working collaboratively? Like, it sounded like you had asked for there to be a case study, but having been on a similar side of feeling, kind of like getting a response that felt like a very neutered, inadequate response after doing a complaint, like what kind of supported your journey to be working in partnership with the health authority? And kudos to you for doing that. Like, that takes a lot of work. Like, it's an exhausting process, so you're amazing. Well done.
Well, I mean, I guess the thing is that the review board, they were the one that said, you know, we need to do the patient journey mapping. And so that was, and earlier along, they asked if they could do a case study, right? But I found out that that was only for one department. And I believe that it should be the whole thing. And that was also basically, when they went through all the charts, it was like from community right through the whole thing to death and after. So I just kept on saying, like, this is what they're saying and this is what we need to do. But I mean, also because Marlene was open to change right and Northern Health in the beginning, and I'm quite willing to push because I saw value in that. And I don't know if you caught it, but I did used to be a nurse and I knew how it used to be. And I knew there was no reason that it couldn't have been better. And that I saw it as, you know, well, that's fine. They could have a clinic on this, even if it was the chart before we got to the video stage or whatever. And I'd be willing to go there. I'm not going to stamp my feet and whine. I just want people to know what happened and how I felt and hear how they can say why it's different and why it didn't happen. I don't know if that answers your question, but I'm determined.
Thank you.
And I can definitely add to that and say that Sally's tenacity, and when you talk about her energy to stay focused on this, I appreciate that she never let this go. So, you know, we can all appreciate, for those of us who work in the system, that we have so many different priorities and things that we're juggling, and Sally just always stayed in contact and just always kept checking in with me, right? And was always open to having that conversation about what would the next step look like, and I really appreciated that she helped keep it on the radar to get us to where we finally landed.
I think you need to hear, too, that they all have busy schedules, and I appreciate that. And sometimes I wait a long time to see them, or if they say, can you come on such and such a day, I make sure to make myself available.
That's very true. Oh, that's true.
Hi, I was wondering, is there some place where we can read the complete report or the complete story?
Do you want to answer? Do you want me to answer?
Will you say your thing? If I need to add, I will.
So we've put this resource on the PHSA Learning Hub. It's not public yet, because when we first started the work, where we saw the potential was it told the story of the lack of person-family-centered care in Jack and Sally's story. And that's important to say that the name of the Learning Hub module is Jack and Sally's story. So Jack is forever immortalized in this Learning Hub module that we've created. And so it exists on the Provincial Learning Hub. So for any of us who are health authority staff, we can access that. We haven't made it public yet because we're still working on some of those resources. So like I said, we thought it was a story of person-family-centered care. We've actually realized there's real potential. It's actually a story of the why of integrated primary and community care. Because Jack's story, my hope today is if Jack had this same experience at Northern Health today, it wouldn't be the same experience. His care would have been better. So we see it as a really powerful learning tool for teams to talk about the whys of improving care and wrapping it around the patient. So we're working on that, about those, to create those support resources, as well as then to make it available.
What I'd like to add is that any information that I got, like when I filled out the application for the review board, all the documentation that went there, when I got that 23-page report back, I would always say, did you guys get this? Did you know that, or whatever, so that ultimately when this thing is fully launched, I would want all those materials to also be available to anybody who wants to go through that journey.
As someone who works in community with seniors on the other side of this table, thank you for sharing. That was amazing of you to share that story and for how you responded to this. My question for you is, this is an exception to what usually happens, and it happens all the time where people have complaints or concerns. And my question is, how do we get this information out to Mr. and Mrs. Joe public, that this is the process and that they are led through it, helped through it, supported, to have their concerns heard, and to feel like it's not, you know, the big health authority against them, because that's what happens.
Well, some of my suggestions are, anyways, I mean, well, because you shouldn't have to necessarily go to the patient care quality office right after the thing. Like, maybe you just need to have a little thing you fill out about the satisfaction of your care experience or whatever, and not necessarily every one of those needs to be followed up, but you might be able to track trends or whatever through that. And maybe people do need assistance to fill out those forms, because I'm reasonably well educated or whatever, and it's still onerous. But if, again, if you're a second language, or if you're older or ill or have a family to take care of, you're just not going to get around to it. And that's part of the reason that I followed through, is because I sort of thought, well, if not me, who?
And then to add to that, I think of a session that I was in this morning on just culture. You know, I think of Sally's experience. If providers or leaders in the system had been willing to talk to Sally in more real time of when her situation had occurred, I don't know that we'd be here today telling you about a Learning Hub module that we created. And so I think the system needs to be more responsive to having discussion about those concerns, because those were some of Sally's requests that she had made. She actually wanted to talk to a home care nurse who had provided care to her husband about some things that had occurred in his care. And so leaders made that happen. But it was, like, how long after the fact, Sally? Was it a year? It was a while after the fact, when you met with a home care nurse?
Probably 6 or 7 months.
Yeah.
Because, I mean, that depended when I mean, I didn't write my letter till March, and my husband died in October or whatever. But then by the time I sort of, you know, they go 30 days or whatever to respond, and then set up meetings and whatnot. And then I thought that it was going to be the study or whatever, but it was only that one thing, one area. And then I said, but I would like to know this, and then that was made completely available. But again, that was only because I had a person, you know, a hands-on sort of meeting with someone, apologizing, and I made a connection. So that was, again, the personal thing that I felt I could go back and approach that person. Otherwise, I never would have done that. So there has been so many incidental circumstances along my journey that kind of fell into place, and so I carried on. There was enough positive reinforcement.
I think that you've been through quite an emotional experience, Sally, and admire your courage that you've demonstrated in coming forth. Now, the question that I've got comes along with all the steps that you've gone through. You have described more completely than practically anybody I know that's been through a hospital experience, especially a terrifying one like you've been through. But in the statements that you are quoting today, I'm wondering if you came down in your final, or maybe it wasn't final, maybe it's still going on, but I'm referring to what some of the doctors will know as the DUMO procedure, where at the end of the procedure, if there's an adverse event, you will be given an opportunity to state you are satisfied with the way that everything has been reconciled. Have you had that opportunity to state, I am satisfied with what we've done, even though it's caused you lots of troubles?
I'm quite satisfied what we've been able to accomplish, but I think we can accomplish more.
Thank you.
Okay. And on that very positive, inspiring note, you have a few minutes to please complete your evaluation. There's paper copies at your seat. There's also the copy that's available on your app. So if you downloaded the app, it's really fast and easy to do it that way as well. Let's give one huge round of applause for all three presenters. Thank you all.